It gives me a distinguished pleasure to introduce to you today Dr. Platt, our speaker. He's an internationally renowned board-certified obstetric OBGYN and maternal fetal medicine specialist based in Los Angeles, California. He joined the faculty at the University of Southern California, where he stayed 14 years, made significant progress over there. Then I was recruited as a chairman in the Cedars-Sinai Medical Center in Los Angeles. Then he opened a specialized prenatal diagnostic center, and that's basically the crux of the reason he's here, to provide with this audience a mechanism and prenatal diagnostic element that remain still in place and useful for clinical practice to this day. He's a diplomat of the American Board of Obstetric and Gynecology and National Board of Medical Examiner. He has authored numerous papers, 350 peer-reviewed publications, 63 books, and has written 5 textbooks. So he wants me to finish, but I will not finish until I tell you that he's presented multiple lectures, and please enjoy the presentation. Thank you. Without further ado, please welcome Dr. Platt.
Thank you very much, Dr. Amar. I really an honor to be able to be here to share some of this with you. You know, it's a challenge when he asked me to do something about bench to bedside. Do you know the definition of bench? Come on, tell me. What's the definition of bench? What you do in the lab? That's the first question. Answer. No. Next. Definition of bench is a long seat for several people, typically made of wood or stone, a park bench. If you don't like that one, I'll give you another one. A long, sturdy work table used by a carpenter, I'm not a carpenter, mechanic, scientist, maybe, or other worker. Now, that's the noun of it. What about the verb? Come on, all the sports enthusiasts. What happens when someone's not doing well? What do they do with them? They bench him. So at the end of this, you'll have a choice either to bench me from the verb or the noun that we've done something different. I'd also like to take it a little bit different and look at it from a different perspective. This really, if I look at my 40+ years in academic medicine and medicine itself, I think we have to define what many of you are doing are true bench research, as what was said first. That's what most people think about it. But many of us in clinical medicine work closely with the bench scientists, and we're a clinical scientist. And we too have much to offer that will be able to sustain the change of the future. I really believe that the people that I was fortunate to work with, particularly at USC Medical Center, where this major work was done, a former faculty member of New York Medical College, whose work I share with this, is Dr. Frank Manning, who some of you who've been here a while know that he was here in maternal fetal medicine, and say that it's something that sustained itself over the course of time. And what we did, and I'll try to develop it as you think in science, things that you have a passion for. The first thing I tell our students, our residents, our fellows that rotate with me, even in my office, I have a hybrid center that really is unlike most private practices, because I travel like this. I don't get paid to be here. I don't want to get paid to be here. I don't get paid to be at work because I'm not at work. Okay. But we're paid by the rewards we get in many other ways. And teaching is one that I get a reward from. I have fellows and residents who rotate from University of California, Los Angeles, from Cedars-Sinai's fellowship program, now from UCSF, residents from all over, basically. So we can share our enthusiasm. And the one thing I tell all of them is, don't do someone else's research. Do it because you have a passion for it. You have the start of a passion and you really like it, pursue it, because it can be involved with the whole life of what you're doing and what makes significant changes, small, subtle, to real big ones that are there. So what I'm going to talk about today is what I think is the fetal biophysical profile and how we evolved, how I got interested in it, and really where it sits today and where we think we're going with this. I have to do disclosures. Of course, maybe CME for this. I do a lot of work with industry. I do a lot of work that gets me to be on cutting edge of science and ultrasound. Yes, you heard Dr. Amar say that you'll hear about prenatal diagnosis. That's not what I'm talking about today. I'm talking about another aspect of fetal assessment. How is the baby doing today? Yes, a lot of my papers are on genetics of fetal well-being and malformations. So I work with, fortunately, with GE developing their ultrasound systems. I do some research for them. Inutero, which is a genetics company. Pulse and More, which is a company, an innovative Israeli company that is actually bringing ultrasound to the mother to home, a handheld ultrasound that the patients have at home. Don't worry, they can't just turn it on when they want, but if they're worried, they can call the doctor. He pushes a button, they can look at it. I looked at Jubal Health, which is a company that's looking at bots in OBGYN, talk about AI and where GPT is at today. Nuvo Cares, which is taking fetal monitoring to the home. We talk about telehealth and what things are going. This is really an amazing advance of what we're looking at. And Trice Imaging, which allows us to share images with our patients. So we're bringing imaging to the patient. So at the end, I think you'll understand what I wanted to say about the biophysical profile and what are some of the current indications. I'm not going to bore this group going over each of these things, just to say that in the past, when I started out in my career, the way we assessed the fetus was biochemically. And here's just some biochemical components. And whether it was high, it was low, you worried about the fetus, because what we all wanted to do is reduce the perinatal morbidity and mortality. The United States has a very high fetal death rate, if you think about it, and a maternal mortality. As an advanced country, we're one of the worst when it comes to it. So we're always looking for something that will provide us with that means to really, how can we cut that and what can we do? And those are the things that we did. So the biophysical profile is in making of how can we use ultrasound? How do we think about it? And what do we do? My involvement in it and Frank Manning's involvement in it started with fetal breathing movements, because there was an association in the animal model, again, taking bench work, animal model that tells us the percentage of time that a fetus spent breathing was an indicator of fetal well-being. And if you can understand, you take the sense of the fetal well-being nature of what it is, we start out and say, maybe we have a new test, because at the time when we started, I was working at LA County Hospital, where Frank was at the time, and that was the capital of fetal monitoring. The late Dr. Ed Hahn, Dr. Richard Paul, he's not late, he's still alive, came and taught us how fetal monitoring can transform what we do and how is the fetus doing the reactivity. I dare say there's not a pregnant woman who's delivered a baby, I should say a pregnant patient who's had a baby, that really understands the role of fetal monitoring, how the re-effect of the head, thinking about how well it's doing. And then we looked at fetal movement as well. We'll talk about that, because there was assessment that if the fetus is moving, it's a good indicator of fetal well-being. That was actually championed by the late Professor Eliyahu Sadovsky in Hebrew University. And the Nonstress test came off of the fetal heart rate monitoring and fetal tone. You know, Virginia Apgar, who developed the 10-point scale of how is the fetus doing at 5 minutes, a 10-minute Apgar score, 1 minute, how is it doing? We said we could look at that fetus. We can look at it, and you'll see as the fetus's hand reaches out, okay? As it reaches out and you bring back in, does it look like it has tone? And I'll show some examples of that. Just static images will show you that. And then we also knew that when we're looking at amniotic fluid volume, and no one really assessed it at that point, we know that the amount of amniotic fluid can also be a reflection of fetal well-being. You know, when we look at an ultrasound and look for an anatomical defects, we're looking at things that are there. They're not going to change. But fetal assessment has a point of time, a reference of time. We want to know, how is the baby doing right now? Not how did it grow to where it did, where it's small or whatever it is. So that, yes.
Look at some of the markers, and markers that I see a number of the estrogen,
Right.
estradiol, and testosterone.
Right.
And what is the significance of, say, estrone, for example, because estrone doesn't stay alone and it's hydroxylated right away.
It had a relation, particularly in diabetic patients. Okay, as it lowered, there was a greater chance of fetal death, and we know that diabetics have a higher rate of stillbirth as well. So that's how that was marked. It's not used today at all. Zero. I'm telling you, no one uses these biochemical markers at all. But that's all we had in the 1970s. Okay. Okay, we'll come back and take more questions later. So fetal movements, I'll go through those, a series of stuff that we've done and we published. And it really was an important factor of fetal well-being using real-time ultrasound. In the past, you had static imaging where you move things up and down, but today, real-time, you can actually see movement, you see motion, and anybody who's seen an ultrasound today, it's no longer the big, what you think you're looking in a cockpit, where you have to figure out all those buttons that are there, but really you put a transducer on, you put the button on, and that's it, you can see. And you can see that's how we started to do studies of fetal movement, not just fetal breathing. And so there were studies of how often, again, not relevant to exact science here to tell you, but it was either you saw how many movements did you see in a 30-minute window, how long did it take you in the morning to feel 10 counts, or, you know, those aspects become very critical to timing. And so when you look at a variety of randomized studies, it was very clear that the relationship of fetal movement was good for fetal outcomes. Could we make this better? And that was our challenge. Could we combine this to what we knew about fetal breathing and fetal heart reactivity to fetal movement? And so here's a number of studies. There's many of these studies that were there looking at fetal movement. No question about it. The relationship to fetal movement has a relationship to fetal outcome. So the nice thing about it is it doesn't cost anything to have the patient remember how much she's feeling. You don't have to bring her in anywhere. We all talk about women today who come in for non-stress testing, that's fetal heart rate monitoring, twice a week, take off of work. Some of them come hours to get there for a 20-minute observation. Our solution to that, I tell you, we have another one that's called home fetal monitoring, which we have that available today too, in new aspects of new things that are available, but it's still used mainly in the high-risk patient, not the low-risk patient. And we know many of these deaths are in low-risk patients. Fetal movement is a perfect one to do that, and where the mother plays a role in what she's feeling. So how did we get into the fetal biophysical profile? So you can see I aged myself by showing that in 1978, first published our work, again, with Frank at USC, looking at the relationship to fetal breathing movement. And what was interesting is that in the animal model, where it was a relationship of the percentage of time that the fetus spent breathing to fetal outcome, in the human fetus, it actually was an all or none phenomenon. If in that 30-minute window, you saw the observation, at least 30 seconds of fetal chest wall movement. And I can tell you around the same time that we're making these statements, textbooks in ultrasound, okay, made it real clear. I can show them. Prominent radiologists, fetus does not make breathing movements in utero. Remember what I said, breathing movements. I didn't say breathing, because remember, what's the exchange? Where's the oxygenation coming in the fetus? Coming from the placenta through the umbilical cord. It's not coming from oxygenation of lungs as we know it. But, you know, like from anything else, how many people in this room, or those of you who are online, think about it, have ever had a cast on their arm or their leg? And if you have, you know what happens when you take off the cast. Can you move your arm so easily? Can you flex? You can't, because it's been stiff. It's been sitting there. Same thing in the fetus. It needs to prepare itself. That's why it does these movements, to prepare itself for coming out. Now, maybe we could argue for a moment and say, what good does it do in the human? We're not as advanced as the animal model, right? Because what happens when you deliver a horse? What does it do when it gets up and runs away? What human fetus does that? And you know what that is, why that's less? Anybody have any idea? It's probably a blessing to the parents that the kid can't get up and walk away right away. Because you can imagine keeping over a newborn. It's enough you can watch them sit in the bed and worry about it. So these are the things that we did, and we realized by the studies that we hear published back in, again, that's 45 years ago. So we're looking at those things. And here you can see the color. Color is just direction of flow. This is Doppler blood flow. And you can see this in and out. Red is towards us, blue is away. And that just shows you that it can be there. And what we did is we wanted to see how much fetal breathing it did. And we did 24-hour studies. We kept on the fetus 24 hours. And here's an 8-hour study observation. And you can see it changes over time. It's not constant. It's intermittent. It is intermittent because it doesn't need to be there all the time, because you have that time that you can change. And here's just an example. People don't believe it. This is a chest wall. Now watch what happens with it. Oh, it didn't work. Okay. I'll get another picture to show you, but this should have showed chest wall movements. Okay, apologize for that. So then the question comes up, if we're looking for an observation and want to be scientific about it, You got to know what can affect it. If I have a 30-minute and I don't see a fetus, do I think that fetus is in jeopardy? Do I think that fetus is at risk of having significant problems? But maybe they were on a medication that stops breathing. Stop the medication, maybe the things will change. And so what we saw is there are some that stimulate breathing. Caffeine, the perfect one, or glucose, I'll show you some studies of that. Or prostaglandins can make the change. And here's breathing at glucose levels. You see the changes that are there. This is maternal plasma glucose concentration. And you see glucose goes up, and look what happened to breathing movements. And so that's something that we use all the time. Patients have heart rate monitoring that looks real flat. We look for variability of heart rate. We give them something to drink with little sugar, short of the diabetic patients. We don't like to do that. But what happens is it starts breathing again. So we have an opportunity to pay attention to that. Time of day, there's a diurnal variation in breathing. So there are a lot of things before you start saying we should use something for testing to understand the basic physiology of what that movement is doing and why it's doing it. Here's cortisol, steroids, and breathing. Same thing changing as it changes over time. Effective caffeine, whether you have high or low caffeine consumption. Again, it takes more time in 4F arousal states that we can look at the EEGs of fetuses, believe it or not. And in active sleep, there's less time breathing. Labor, can it predict labor? Look what happens as you take a control and you get towards labor. Breathing stops. So do I have enough sensitivity and specificity to say, she's going to go into labor? The answer is no, we do not have that. But you can start to see, if you see a change, you might think that. So that's not going to be our predictor, our magical wand for that. Onset of labor, you can see days before delivery does change over the course of time. So then we said, okay, that's when we started to think about what else can we look at? And then I'll show you how this fits in real life of outcomes. We thought about fetal tone. Can we measure the tone? You know, as I said, Apgar looks at tone. Does the hand flexed? Does the hand squeeze? Does the back arch? These are what happens when we see a newborn. That's what every obstetrician, the nurse in the delivery room, the neonatologist will look at. How is the baby doing? Does it have that tone? Because we worry about neurologic effects of these babies, and can it make a difference? So we realized it's a dynamic variable, and we could see the same things on ultrasound as we saw the other. So if you kind of look at it this way, it's kind of little classic pictures that you've seen, right? And if you go further, this hand looks it's up there. It looks like it's pretty good tone. It's not doing anything differently. I took out a picture because I didn't want to have it in there, but it's, can you imagine looking at the third finger in the middle finger up? That's stone, let me tell you. But if you want to see that one, I'll be glad to share it another time, but didn't think it'd be right to show here. So the other thing is, what changes these things? What allows the change for us to recognize, okay? And recognize that something's going on, okay? If the baby has a fetal heart rate monitor and it's rather flat, can I do something to stimulate it? And so again, we wanted to see, does it change the tone? Does it change what happens to the baby? So anyone have ever seen an artificial larynx? It's high decibels, and you see we put it on the uterus, and you can see you get reactivity after you buzz the baby. We call it buzzing the baby. It stimulates it, and the patients feel it, and it goes to the baby, and they can feel it as well. And here's a stimulus, and you can see the incidence of breathing changes when you do that, but it doesn't, it gets the baby's heart rate reactivity. Look at bladder, causes the baby to pee. So it changes something on it. We know that if we do external environment on this fetus, it will change the course of that activity. We also noticed in the study that we did is that we actually took ultrasound, buzzed the baby with an artificial larynx, and watched what it did. And there was an immediate forearm movement when that stimulus went on, and it lasted about 8 seconds. So it showed us that we can, in a healthy baby, change the state of the fetus and help us better assess the fetal condition at that point. And that's what an artificial larynx is. You know, those who have the problem with their vocal cords, put it up here, yeah, hear the raspy sound, and that's what it see. And if you can see, this is what happens. You read that? Okay. So that's what has started saying, okay, what should we be doing? Now, we're working in the fetal monitoring mecca of the world. If you look at the literature, you'll see that most fetal monitoring papers came out either from early Yale, when they were at Yale, then they moved to USC, with Dr. Hahn and Dr. Paul and Dr. Quilligan. And what we saw is that you not only have to use contraction stress tests where you start a contraction, you look and see what happens to the heart rate. And if it's normal, it'll stay up or go up higher. If it comes down, it could be head compression. So that's what we call a early deceleration. But if it occurs after the contraction, when it's cutting off blood flow to the baby, you may very well be forcing yourself to see asphyxia in these babies. So the non-stress test was just looking at a fetal heart rate monitor, seeing about reactivity and accelerations with spontaneous movement, not so much deceleration. And it has a very low false negative rate. In fact, if it's once a week in an average patient, not the higher risk patients, we'll do those twice a week. It has a very low false negative rate. And on the other hand, there is a high false positive rate. Doesn't mean these babies are bad. And so we look for either 2 and 10 minutes accelerations or 3 and 15, not relevant again, but just to know that these are the things that we look at. In terms of amniotic fluid volume, we also were early people to report that the relationship to the amount of amniotic fluid that the patient has, the fetus has, which we could now measure with ultrasound, which we couldn't do before, was a relationship to outcome and particularly fetal growth. Because babies that are not putting out the same metabolic rate and growing slowly, they don't urinate as much. Remember, amniotic fluid is baby's pee. Okay. Yes, the baby swims in it all day long and swallows it all day long. But those that have decreased fluid, we need to evaluate for reasons. Why isn't the kidney functioning and what's there? So it really has a very strong marker of poor reproductive outcome. So here's what we came up with: a maximum vertical proctor 2x2. You can see the dark area is fluid. This happens to be the nares of the nose, the little mouth that's here. And we looked at that throughout the gestational age and saw a relationship to decreased amniotic fluid. Here's one with less than a centimeter pocket. This was way too tough when we first published it, for sure, because these babies are really not in a great shape when they get just a centimeter of fluid. And very clearly, that is the relationship. Then we started to put all these 5 parameters together. We said, what if we kind of think about Virginia Apgar and 5? Because look, we can measure tone, we can measure reactivity, we can measure breathing, things that she does. Well, we may not see color, but we can do all those neurologic status that they use in utero. So it's like an in-utero Apgar score is the way we looked at it at the time. We didn't call it the in-utero Apgar score, but you better believe we used the 10-point scale for that exact reason. What we didn't do, and someone tried to change it and it didn't work for them, is use 0, 1, and 2. We kind of went back on the all or none phenomena. It's either a 0 or it's a 2 for each of the 5 components.
How would you correlate the amniotic fluid volume with a pulmonary function, which is
so we know. So the question: how do we quantify amniotic fluid volume with pulmonary function?
and how does it?
Because
relate
very
to that?
clearly, oligohydramnios does not support lung growth. Oligohydramnios, if you have real oligohydramnios, these babies are going to be born with pulmonary hypoplasia if it's prolonged. So you want to not leave them there under that circumstance for a long period of time.
So does that mean that when you have asphyxia, they pee more?
Depends. If they have asphyxia, they're not peeing at all. It depends what the reasons for asphyxia, right? But if they have, because they're not growing, okay, they're not putting urine out, they're prolonged time of oligohydramnios. There may be other genetic reasons for this. Believe you me, there's many mutations that we see now with oligohydramnios, significant syndromes that may be the cause. But otherwise, the ultrasound of the kidneys look normal. And you have oligo. And the best way to think about it for a moment, what if you have ruptured membranes at 28 weeks and the patients stay in utero? You're not terminating that pregnancy. If it stays oligohydramnios over that time and they don't accumulate it, their chance of pulmonary hypoplasia goes up significantly. Okay, so that's part of the exchange, and there's actually fluid across the lungs that get exchanged that make a very big difference. And so what we surmised and what we started to look at, and you'll see the curves that we show, that a score of 10 out of 10, with each of the parameters know, the risk of asphyxia is rare, and even the same for 8 out of 10, particularly if you have normal amniotic fluid volume. If you have abnormal amniotic fluid volume, there may be some chronic change that's there. As the scores get lower, the greater chances of asphyxia. And that's when you have to intervene. You have to do something differently. Now, around that same time, in the antenatal testing, my associate, Dr. Phelan, took some of our work and said, what if we took 4 quadrants with the fluid instead of 1? And indeed, that's what they call the amniotic fluid index. We think you add 4 quadrants of fluid. What's the deepest vertical pocket in each of those 4 quadrants using the umbilicus as your middle point, and come up with greater than 5, then you're going to be okay. And this is the curve that shows there. As you have those curves, you can see that that's a very important assessment. So that's when we decided, what if we took these variables and what will happen? And as I said, the primary means of assessment up until this point was either the contraction stress test, which we gave the mother Pitocin, or she actually did breast stimulation that causes contractions, okay, and look for the change of the heart rate, or the non-stress test, which looks at just a quiet heart rate variability. And what we found in that, what we think is probably our landmark paper, a major paper on this, was that for any single test, the false negative rate was low and similar between tests, and the false positive rate was high and varied significantly between tests. Okay, very important. We'll show these. So we measure these 5 variables. These are the 5 variables that we reported on that I showed you. I gave you a clue to them ahead of time. Non-stress test, fetal movement, fetal tone, fetal breathing movements, and amniotic fluid volume, each getting a score of 2. When you combine the tests, both the false negative and false positive rates as compared to any single test was the better way to go. The most accurate differentiation was obtained when all variables are used. And some tried to suggest that, get an 8 out of 8, you're good. And my colleague, Frank Manning, who I guess was here on faculty, we differ on that, because I said you got to use the non-stress test. There's too much important information. And to this day, I still stand by that you need all 5 parameters, not just 4 out of 4, because you start worrying if you don't have the heart rate in there. That's one that bothers me. So what we've found over time, these tests are markers for fetal asphyxia. We're abandoned the clinical ones because of low specificity and low sensitivity, the biochemical ones that we talked about earlier. Using these based on 5 ultrasonic markers of assessment, again, we did not allow, as I said earlier, for the intermediate scores. And is a single number enough? We don't think so. The answer is no, I don't think so. So here's what it looks like. Here is a score of 10. This is from our initial paper. The relationship of fetal biophysical profile to perinatal death. A score of 10, you start going on, you go down and down and down. Look at that, score is 0. This baby is an almost dead baby, very, very sick. But the scores continue to go down, you're dealing with a sicker and sicker baby. So like the Apgar score, the lower the score, the greater the chance you're dealing with asphyxia and some other problems. This is another way to look at it, the normal tests. You can see this is perinatal mortality per 1,000 births. You can see that the number for the normal test is pretty low. You start talking about the abnormal test, the individual parameters, look at how it goes up significantly. And again, as I said, when you combine the two as a process, and this is the same thing that I showed you, but this shows you patients with fetal distress, almost 100% of the patients who have no positive variable will have fetal distress, and almost 80% with only a score of 2, even if the heart rate looks okay, or even their breathing. It's a combination of these factors that make a difference. It's more than one factor that you're looking at that really will change the face of what we're doing. So our conclusions is really clear. The presence of a normal or modified biophysical profile, which is commonly used today. And what is that? Because it's an easy way out. You just do a non-stress test and look for the amniotic fluid volume, because probably those are the strongest things you need. But for them that don't want to spend 30 minutes doing this test, then that is an acceptable approach. But no question, doing the full biophysical profile will make a difference. And here's again what we would do. And so if your score of 10, you would not intervene for anything except for maternal factors. On the other hand, if you have a 6 of 10, there's no normal amniotic fluid, we deliver for fetal indications. With one caveat, what gestational age are you? I remember having presented at one of the meetings, and one of the radiologists was talking about, one of the presenters was talking about, well, they just had this case. What would you do, Dr. Platt? They'll tell me about the case. And they went to proceed and tell me about the case. And she had very little movement and she had no breathing. And there was really some reduced amniotic fluid. Would I deliver her? I said, you're looking at one important factor. How many weeks was she? She was 22 weeks. I wouldn't deliver her 22 weeks. I know what outcome I'm going to get by delivering someone 22 weeks. You may have an intermittent variable that you got to do the things that you can change. Put her on her left side, give her oxygen if you need it. See what else is going on. Put the whole picture together. It's not isolation. It's not just one test. It's the combination in face of what the patient looks like and what we're doing. So clearly, as you go down in the score, the risk is greater. And here you can see the perinatal mortality and corrected perinatal mortality rate, which is very, very important for us to look at. And the time, as I said, in this country, when perinatal mortality is very, very high for certainly a country like ourselves. And again, outcome, fetal distress, see what happens. Admissions in NICU, 5-minute Apgar score, cord pH, acidosis. So the lower the score, the greater the chance you're dealing with an acidic baby who has fetal distress and to worry about. So the question you came up with and they keep asking us all the time is how good and for how long? And as Gertrude Stein's last words, but it depends on the question you're asking. Why are we testing the fetus? What's wrong with it? Is it gestational diabetic who we're testing because we know they're a little higher, but they're not severe? Or it's a baby that has severe intrauterine growth restriction who is really at high risk for fetal distress and fetal compromise, things that we need to think about for sure. Then the next question is, what do you do? Non-stress testing with a biophysical profile. And when we compare the two, NST is a sensitive but not specific test. It's inexpensive and fast. The biophysical profile requires a sonographer to be present one-on-one or a physician to be one-on-one doing it, and you need the time to do it. So that's when people decided we could do the NST with the amniotic fluid volume as an alternative. As I mentioned, I'm happy to be working with a product that's home-based ultrasound where the patient can actually put it on. And we can teach her how to do fetal breathing. So maybe that'll change as well when we have those available at low cost, because the average ultrasound machine that you may see on the wards up here, you have them ranging from 150,000 to maybe 30,000. This is a $500 machine, so that you can see the aspects of what we're seeing. So these are the things that we need to have. What are our tools that we have? How do we make a difference? So when we look at which test to do, you got to have sufficient time. It depends on the examiner's skill, both in ultrasound, biometry, and anatomy. You have a baby that has multiple malformations that may not be compatible with life. I'm not sure what we're testing. If it's compatible, we got to know when we intervene, because sometimes intervening for the patient with a malformation at the right time is much more beneficial than waiting for her to go into labor, and those make a difference. So here's a schematic again for the group here. It's not critical, just to say we act on the results. We intervene based on the whole circumstance, not just one isolated thing, and try to make a difference on the others. So I could easily conclude here, and I just go through a couple slides more to tell you that's been widely adapted. It's still used. And there are people out there who maybe not believe it as much, maybe in the right. What are we testing for? Well, you know, we haven't done our homework well enough to do what we call disease-specific testing. What are you testing it for? What is the disease? Growth restriction, the worst of all. High mortality, high morbidity. Gestational diabetic, change your diet. You'll probably get better. You won't have the same thing, even though their risks are a little higher. And so there's been some recent papers, and I'm just going to go through the systematic reviews. They suggest that in 1996, there wasn't enough randomized clinical trials. We did not do this study the way you should probably do all tests. The first test you do should be a randomized clinical trial, but very clearly it showed that difference. And again, as you can see, the changes that are there, these are other reports, and looking at the cerebral umbilical ratio, looks at blood flow to the head and stress. The profile is a useful indicator for early detection in fetal hypoxemia, as you can see here, okay? And I think it's important to realize that there's a variety of different individuals. The management of growth restriction has changed dramatically over time because of our ability to manage growth and look at subtle changes, fat, the length of long bones may be a difference. But one of the reports in 2007, and we're a long way from that away, there was no evidence that supports either fetal heart rate monitoring or the biophysical pro improving perinatal outcome. Most of us may not believe that, but again, that's what we got to look at what the literature says, because maybe there weren't enough papers. Here's some more of the same thing. The trials, again, insufficient evidence from randomized clinical trials. Doesn't mean that they didn't see evidence of the other trials. Clinical assessment in many, many cases and many papers, because we're not the only authors of this. Another one, the same thing. It's good to providing reassurance for 24 hours, but not applicable to the severe preterm. where the baby is small and earlier, that may not be as sensitive early as it is late. On the other hand, if you see fetal breathing and a good heart rate activity, that baby's probably okay to remain inside, even though she is going to be small. And again, when we look at guidelines for the growth restricted fetus, again, the ACOG and define abnormal growth differently. And so the recommended management between the Royal College of OB/GYN, the American College was a little bit different. And what they came up with is you got to think about what you want to do. And again, disease specific indication. Why are we doing it that way? So you got to take a step back and take a little yawn and say, which way should we do it? Then, okay, we recently published a role in the growth restriction. Why did we publish it? It was a rebuttal. It was a rebuttal to a paper that came out from my own professional society, Society of Maternal Fetal Medicine. And here's Frank Manning and myself, as you can see. And that took the guidelines in April. They replaced the 2012 one to a paper. This is in 2022. As you can see, basically, their recommendation was that it didn't show it enough to be used in a growth restricted baby. We published subsequently that paper to prove with the data that we have, the data that's been published, that it in fact does work. So at the end of the day, what have we learned about fetal assessment? What have we learned today that we didn't know yesterday? What work do we still have to do? So it should be initiated when you're thinking about there's an abnormal fetus, the status is normal. It can be used fetal surveillance late in the second and early third trimester till the end. The fetuses with biophysical profile score and with growth restriction uses the same criteria as any other high risk. And again, the presence or absence become very important. And the scores that we talk about really will help us reduce perinatal morbidity, which every study that's done with the fetal biophysical profile has shown to date. And again, this is just repetitive to what I showed you in the curves, that the abnormal, for example, the abnormal score indicates that fetal pH is likely abnormal, requiring delivery. And the abnormal score does represent acidemia. And those are why you need to intervene. And the lower the score, the more information you have, the more sensitive and the more specific the test becomes in these predictive states. In patients, on the other hand, with a normal or equivocal, you got to manage them as you would any other patient based on their Doppler ultrasound, which is incredibly important. And that's the variety of Doppler of the brain, Doppler of the umbilical cord, and other assessments that we use. Know how the mother's doing. The mother's real sick, you know what you have to do. I mean, sometimes the mother is so sick, you just have no choice for maternal reasons, not fetal reasons. So we have to balance the risk of mom against the risk of the fetus and put it as a unit that becomes it. And we think that's what the biophysical profile has allowed us to look at the fetus perhaps as a patient. We don't know when we talk about beneficence or autonomy, whether or not who's in control, because that becomes a very difficult question to ask. But when you start looking at new indications and new findings, we think that there's a major. So overall, all these things, the integration of our testing schemes become very important. Sometimes we have patients on monitors consistently 24 hours a day, a burden, a lot of wasted paper at some time, but now we're electronic. We don't have to have that much paper. But I think it's really, we have to be able to be flexible enough to use all of these tools that we have available today with ultrasound that we didn't have before. I thank you very much and be glad to answer any questions you have.
The paper is open for any discussion, please. Yes.
Thank you. Very nice talk. So while maybe not quite as clinically useful because of the complexity involved, I wonder what a regression-based scoring approach would give you. This would allow for weighting of the different factors.
Well, we did some of that, okay? And if you look at it, again, it depends on what you're testing and what the indication for testing. Because immediately you scan a patient, she has decreased fluid. We already know it is decreased fluid. And if the baby's growth restricted, we know that that regression for that is going to be the highest, right? So if I had to say, again, from my interpretation of data, overall, there may be individual variances. I like, honestly, the fetal heart rate tracing, the non-stress test, as to me, the highest score, but the differences are not that great. But when you put all of them together, remember the picture that showed you, you put them together, there's no question putting all five together was the best discriminator than one or two. But if you didn't have a scanner available, you'll have a fetal monitor, that's what you're going to use. And that's why I said what they're doing today is the modified biophysical profile, which is probably used more than the complete biophysical profile, is amniotic fluid volume and a non-stress test. And that's based on regression.
Right, that's so, yeah, so because it can't be the case that they all.
They're not the
are
same.
the
They're not, I just said, that's why we end up with two, right? And that's where it comes to be.
Would you consider adding other scores that exist out there?
People have tried, but nothing's happened. Nothing's worked. They try to add the placenta, for example. What does the placenta look like?
Yeah.
Placenta grading, it's a very important element of what we're doing. Didn't make a difference. The late Peter Granum at Yale tried to add a score for grading of the placenta, because we know that the more mature the placenta is, you go from score grade 1, 2, 3, lots of calcifications and not getting the perfusion there. That is the problem. In fact, today, what do we do with patients who've had previous history of hypertension? We give them aspirin. In fact, almost in Europe, it's routine. We take any high-risk woman, twins, woman over 40, okay? We give them 81 milligrams of aspirin every night. And what do we do that for? Increase perfusion through the placenta. Okay, so the answer is, yeah, the placenta is a very important one, but there's no marker that we could use that really makes it. Have people tried to look at the elasticity of it to make a difference? It hasn't helped. Do we want something else from it? We'd love it, because we know how vital that organ is, right? And in fact, if we talk about, we just had a paper on COVID and outcomes, right? And so we know that there have been placental changes noted in COVID patients. And therefore, could that help? The problem is you can't discriminate it so well. We need a better way to discriminate that.
So the criteria that you mentioned,
Mhm.
say from 22 weeks to 34 weeks.
To 40 weeks, 42 weeks for that matter.
Question is, what happens when in a sudden hypoxic condition that prevails, where which criteria do you think is more vital amongst the five?
First, we know one thing. The patient with a normal test, okay, there'll be a higher mortality rate than those that have an abnormal test. You know why? We're going to intervene, right? So we're not going to intervene.
Right.
We're not going to intervene. We're not going to intervene for those that have a normal test. And just, we know mortality and morbidity will happen for a variety of court accidents. People like to claim that. I'm involved with a series of well, I've been involved. One of the reasons is how do we reduce stillbirth? That's really what my mission was. Where's the most catastrophic things we see? Women with stillbirths, right? No explanation, stillbirth. And so there's been some work suggesting that placental size may make a difference. The truth is, most of us don't really believe it, but it's out there. And that environment of women who had stillbirth, man, anything they can pick up and read about it, they're holding their hat to it. Can you measure this placenta? I don't know how that's going to make a difference. And even the people in that person's institution doesn't have that same confidence. But you go anywhere, and I'm going to speak in 2 weeks at a stillbirth foundation meeting. I guarantee I'm going to hear it time and again. What are you doing with the placenta? How's it going to make a difference? We don't know. Okay, you want to put them on aspirin? I'll put them on aspirin. No question. I'm not worried about that. These patients have significant PTSD, I can tell you. And I say it publicly. My daughter-in-law had a stillbirth at 38 weeks a year and a half ago. Trust me, I know what it's like. And I know the PTSD that she's gone through with it. Okay. And then they do the next one, and she got pregnant, thank God, and delivered a baby at 37 weeks. Baby was in the NICU for a month on a respirator and had a chest tube from pneumothorax. Okay. I mean, thank God she's doing well. But the bottom line is lots of anxiety. But we'll never predict it all. We'd like to find out the magical cue. I'd love someone to tell me a test that works a hell of a lot better than this. We'd love it. That's okay. Put me out. Maybe it says that the 40 years it's still there. We haven't done our job to find something even better. I have no problem hearing that. I have no problem seeing that at all. I have no problem telling me that it may be cost effective to do the modified biophysical profile, amniotic fluid volume, and the fetal and the non-stress test than the whole thing. That's okay too, because it's probably more cost effective and we can reach more patients there. And I think today, as I said to you, I could show you a picture of what a remote fetal monitoring, which patient has a belt on both sides. Okay, there's transducers there. And remotely, we can read the heart rate monitoring from her home, from work. She doesn't have to leave work like we talked about. Or I can teach her on the ultrasound for herself to help us see how her fluid looks. We're going to see that change over time. Have no doubt about it. We don't want to overdo it though. That's the problem. And you don't want to overdo and over rely on some technology. You know, that's our challenge. Our challenge is doing what's right, doing what's safe, and doing in the best interest of the patient. And not every patient wants to deal with these things. You know, we have lots of different patients that come into the hospital. I sit as a chair of a peer review committee where one of the hospitals that I'm head of maternal fetal medicine, and there are patients who want to deliver at home with no one, a midwife, even with twins, and we really worry about it. They don't want you to intervene when you should intervene. Can't force them. And so the same thing is we don't want to underdo, we don't want to overdo. We have to be sensitive to what we do. We have to treat them with respect. And when I said about the fetus as a patient, you know, who's the real patient? Is the mom? You know, should the mom have surgery to repair something in utero? That's now a risk, not only just it's a benefit to the baby, but no risk to her, no benefit to her, only a risk to her. So we have to balance those things that we do. And people's enthusiasm sometimes push people the wrong way, and we have to be balanced to think it the right way.
I have a
Come on.
daughter who I hear all these complications every day.
It's true. You know, and it's the variation of care around this country, around the world is incredible.
Yeah.
And you talk about equity and diversity. Let me tell you, I mean, it's incredible.
Even in Manhattan, it's different, it's same, different hospitals, care is very different.
You know, I get it. I live in Los Angeles. I can assure you that's correct.
Any other question? Hearing none, I'd like to think again.
And now they know, wait, is it a bench or a bench? A noun or a verb?
It's a knockout.
Thank
Thank you very much.
you all. I really appreciate it.